Welcome to Barcelona, one of Europe's biggest cities and hub for sport, art and now urology. As the 34th annual EAU Congress gets underway, the top minds in urological research and clinical excellence are coming together to discover the very latest science and get to grips with the most up-to-date guidelines and techniques. We're here all week to make sure you don't miss a thing. It's EAU TV. Urologists are gathering from around the world here in the magnificent Fira Gran Via, ready to share and to discover some of the latest state-of-the-art developments in urology, from uro-oncology to urolithiasis and everything in between. We're EAU TV, and you can watch us here on site, online and in select hotels. And we'll be bringing you the very latest news and views from some of urology's top minds. Right now, behind me, the opening ceremony is about to kick off. But first, let's look at what exciting features we've got coming up in today's show.
The patient wants the best, and that's difficult. It's difficult because what is the best? And that's for one patient is different than for another patient. And that's what the whole meeting about.
The Wesley offers really the latest technologies and procedures across the range of medical and surgical disciplines.
Because PSA has been discouraged, there is now an increase in prostate cancer mortality in the United States. There is in the United Kingdom more and more people that are diagnosed late with advanced or metastatic disease.
We need to educate our radiologists, we need to educate the urologist, so that you can discuss in the multidisciplinary team with the radiologist the findings. And only if you do that, these results will be applicable in the general population.
Our philosophy is to place the patient first. It's not just a slogan, it's important to all of us.
Expert-guided tours are invented to have really interaction between the ones who are presenting their work and the people that are experts and discuss the content.
We found an increased risk of depression in all patients who had undergone a radical prostatectomy, and especially the patients receiving ADT had an increased risk for up to 18 years after surgery.
But before all that science, let's soak up some Catalan flavours as EAU 19 begins.
Welcome, ladies and gentlemen, to Barcelona, to the EAU. EAU 2019, I think, is going to be a fantastic meeting, as you can already see from the first day.
Well, what a fantastic start to EAU 2019, and we're sure that Annual Congress will deliver on that promise. Now, today we're going to be taking a closer look at prostate cancer, from the latest science to EAU policy and the associations for mental health. I'm outside the 6th ESO Prostate Cancer Observatory, which is just about to begin, so let's take a look. ESO observatories are high-level sessions which aim to provide updated and unbiased information. This session focuses on innovation and care for prostate cancer over the next 12 months, with a panel of distinguished clinicians, scientists and a patient advocate, all providing forecasts for the next year, followed by a discussion. Can you summarise very quickly what happened in the session?
Let's say, for example, MRI. We should make an MRI for every patient before biopsies. I think that's a clear message. Should we do it? We don't know, because there's still discussion. Should you take random biopsies also? So a lot of discussion, but I think MRI first. That sounds reasonable. Then we have active surveillance, and they also nicely had some comments from patients in the room, because I liked it that there were also patients in the room. They said active surveillance is so important. You have to do this. Then we had the urologist talking about radical prostatectomy, and that's our bread and butter, you say, yeah? That we like to do radical prostatectomies. And who should we do it? Well, not in the low risk cases, that's we agree on, but in the high risk, we do it more and more. Even advanced cases, even metastatic patients, we do radical prostatectomies.
So John, from your perspective, as a patient's perspective, were you happy about what you heard today?
I think I was there, I suppose, to sell the idea that the profession should be concerned front and foremost with the quality of life of the patient, and I think the sense that patients sometimes are quite willing to trade off some degree of overall longevity for quality of life, and certainly quality of life will improve if some of these things that we heard about today become mainstream.
The most difficult is to make a choice. What kind of treatment should we give to the patient? And I think we have to do it together as urologists or as radiation oncologists, also medical oncologists, but the patient wants the best. And that's difficult. It's difficult because what is the best? And that's for one patient is different than for another patient. So what is the best? We don't know. And that was the whole meeting about.
Next, let's go to Brisbane in Australia, where the Wesley Hospital is a leader in treatment for prostate cancer. And they are providing innovation through collaboration with some of the world's top urologists.
It's the people in the Wesley that really make it the hospital that it is. We have a very collaborative and collegiate environment, and that naturally translates into good patient outcomes. Wesley is a metropolitan, not-for-profit tertiary teaching hospital that's located in the city of Brisbane in Queensland, Australia. The Wesley offers really the latest technologies and procedures across the range of medical and surgical disciplines. The robotic program at the Wesley started in 2010 and has really grown since then.
We're the only hospital in the country with 2 XI systems. We've done over 5,000 robotic urology procedures here. Most of our work's prostate cancer and prostatectomy, but we've done more than 16 different urological robotic procedures. We do cystectomies, nephroureterectomies, partial nephrectomies, nuclear prostatectomies for high volume BPH. We've got a lot of very experienced robotic urology surgeons.
The Centre of Excellence accreditation has been an acknowledgement of the whole team that works together to ensure really good, excellent patient outcomes. We're very fortunate at the Wesley to have a group of very well-trained urologists. Many of us have done international fellowships at leading institutions, and we've brought back those invaluable experiences for the benefit of patients. We've been very fortunate to have excellent collaboration with international colleagues. I'm very grateful to Professor Bocchiardi and Professor Galfano in Milan. We've been in constant communication with them. And we were very fortunate to have Professor Eden from the United Kingdom and Professor Ra from Yonsei University in South Korea come and visit us here at the Wesley. They ran Australia's first Retzius-sparing radical prostatectomy workshop here at the Wesley Hospital. We're introducing it in a select number of patients, and so far the early outcomes, I must say, have been excellent. We're continuing to examine to see exactly what its place and what its role will be in prostate cancer management.
NanoKnife is irreversible electroporation, which is a new technology that does not involve surgery or ionizing radiation. Professor Stricker is regarded as one of the pioneers of NanoKnife in Australia. And when we decided to proceed with the NanoKnife, I went to Germany and Professor Stricker's unit. When we commenced the NanoKnife program at the Wesley, Professor Stricker was able to send his PhD fellow to mentor us in the first dozen cases or so. So far, we have had good success on the dozen patients or so that we've treated.
Brachytherapy is radiation dose intensification where we're adding extra dose to the prostate to try and improve local control of prostate cancer compared with external beam radiation treatment. We started our high dose rate brachytherapy program nearly 19 years ago at Wesley. We treated more than 1,000 patients over that period of time. Our low dose rate seed brachytherapy program started over 15 years ago. We work in very close collaboration with the radiation oncologists. The urologists put the needles in theatre and the radiation oncologists do the planning live in the operating theatre. Then we've got a robotic delivery system that delivers the radioactive seeds to the patient.
There is no doubt that one of the key reasons the Wesley has been a successful hospital is through collaboration and interdisciplinary collaboration, particularly with radiation oncology and radiology, has been critical to provide what is the best outcomes for patients.
It was through the vision and cooperation of urologists and radiologists that saw the Wesley become the first hospital in Australia to introduce MRI scanning for prostates. For the first time, it's allowed radiologists and urologists to see inside the gland accurately and to be able to detect significant cancers. MRI prostate study was a direct result of working with Radboud University in the Netherlands and Professor Jelle Brandts, one of the world leaders in MRI prostate imaging. MRI prostate is now almost universally available across Australia. That has led to so many advances on many other levels. The Wesley Hospital is the first hospital in Australia to introduce PSMA PET scanning. We have one of the largest and most experienced MRI-guided biopsy services, all having a very beneficial effect on patient outcomes.
Imaging, looking at nuclear imaging in particular, and then expanding that into therapy with theranostics. I think these will be the areas that we will see growth and development and innovation in moving forward from here. The key to success at the Wesley Hospital has been our culture and our collaboration. In doing that, we've been able to learn from each other and bring back a whole host of knowledge and skills, bringing in new procedures and new innovations so that they're available for our patients.
Key evidence has emerged to demonstrate that a lack of prostate cancer screening is reversing the trends of declining death rates. As a result, the EAU has initiated a second policy paper addressing the need to reconsider structured population-based PSA screening for prostate cancer. What's changed in the research into the use of PSA screening?
We have been misusing PSA in the past and we are using PSA much more cleverly today. We do not over-detect cancers any longer, we do not over-treat them, and we have the tools to really use PSA in a smarter way. The strongest study performed is the European Prostate Cancer Screening Study, and we have now analyses from sub-cohorts, for instance in the Netherlands, with 19-year follow-up, and we see a more than 50% reduction in prostate cancer mortality and in metastasis. So it's really obvious that prostate cancer screenings will improve prostate cancer mortality.
What's the content of this paper and why has it come out now?
The paper is actually highlighting we have had an evolution since PSA has been introduced of a steady decline of prostate cancer mortality. And this has come to a stop. Because PSA has been discouraged, there is now an increase in prostate cancer mortality in the United States. There is in the United Kingdom more and more people that are diagnosed late with advanced or metastatic disease.
As this policy paper has come out, what is the EAU doing to work with the EU on this?
Well, we have tried to bring this to the attention of the European Parliament. We had a session, the European Prostate Awareness Day in the European Parliament, just a couple of weeks ago, where the MEPs and the MACs, which is the MEPs Against Cancer, have promised to support us in the European Union to advocate to the member states, because it has become, in some countries in Europe, the second leading cancer cause in males after lung. And nobody cares about it, and nobody says that we have to do screening, although this will dramatically decrease prostate cancer mortality.
Every year, EAU sees a wealth of new data from a wide range of trials. Well, all this week we'll be hearing from some of the authors presenting their latest trial data. We'll be delving into that research as they're quizzed by their peers. And right behind me, we're setting up for our first one.
MR imaging has a more and more prominent role in the detection of clinically significant prostate cancer. However, the capacity is very limited, and that's a real problem. Therefore, we investigated which parts of the MR examination we could omit and still have a good diagnosis. Also, we investigated whether we could get rid of contrast agents, because this makes the examination invasive with potential side effects. We found that with a short MR sequence, we can double the number of MRs. That means we can halve the time needed for imaging. One can safely use a fast protocol which will double your MR capacity at lower cost. And I think this makes this technique eligible for screening high-risk patients.
Yeah, no, thank you very much. I think this is really important data and interesting data, and up to the point what we need today to improve capacity to do MRs in our patients before a biopsy. Still, it is done by dedicated experts. Probably they're not better experts in the world than those who did this study, with you being part of the leaders there. What makes you think, though, that this data is reproducible in a general MR service somewhere else outside of expert centers?
How you acquire the images is very important. If you have a bad image, you have a bad diagnosis. Then second, you need to test the radiologist, and third, you need to test the MR fusion biopsy. So I think there's a lot of work to be done. We need to educate our radiologists, we need to educate the urologist, so that you can discuss in the multidisciplinary team with the radiologist the findings. And only if you do that, these results will be applicable in the general population.
Dr. Burns, your results are very good and very good news for our patients. Do you think that your study is a strong rationale for a further clinical trial, randomized, where in the intervention arm there will be only this fast biparametric imaging?
We need to use our technique in a multi-center prospective randomized trial over Europe. And we need to combine our forces with all the countries in the world. And actually the EU Parliament has made a statement which tells that every country in Europe should screen patients for prostate cancer. And I hope that we join forces and that we will be able to set up such a trial. And I'm willing to dedicate my time to set up the trial and to help.
We want to create an institution which can deliver services at an affordable cost to every member of the society.
The patient has every option, every modern treatment which is available worldwide.
Our vision is basically to serve poor people at an international standard and at an affordable cost with ethics and values.
The Wesley offers really the latest technologies and procedures across the range of medical and surgical disciplines.
Our Department of Urology and Uro-Oncology at Albertine Hospital in Hamburg is one of the most modern departments of northern Germany.
Our philosophy is to place the patient first. It's not just a slogan, it's important to all of us.
Thank you, Professor Barentz. Some exciting results there and new hope for prostate cancer patients. Next, let's go to Switzerland and Hôpital Universitaire de Genève, a state-of-the-art prostate cancer centre where they're training urologists from across the country.
Geneva University Hospital is the largest hospital in Switzerland and an international reference centre. Our philosophy is to place the patients first. It's not just a slogan, it's important to all of us. In this perspective, in 2017, we have inaugurated a new building for in-house patients, offering modern equipment and comfortable rooms. Our institution's urology division is the fastest growing clinic of the Department of Surgery. It provides specialized care with state-of-the-art technology for minimally invasive treatment. Its chairman, Professor Iselin, and his team have pioneered laparoscopic surgery. They have developed an active robotic surgery program in our institution. I'm extremely proud to have not only great professionals, but great teams taking care of our patients.
We have really tried to intensify the individual management of the patient. Urology is a subspecialty which digs deep inside the intimacy of the patients, much more than other specialties. So it is really important to develop that sort of confidence relationship with the patient.
Prostate cancer is a particular disease because it touches many aspects of man's health. It is not just a cancer that can be life-threatening, but it's also a disease that has effects on functional aspects of the man's body, in particular urinary continence and also sexual potency. It's a disease that is also complex because it has many different forms and manifestations. It can be a small, localized disease that only needs surveillance, and it can progress up to a stage where it is generalized and needs systemic treatment.
The developments are evident. For instance, if you look at the number of doctors working in the division, it has more than doubled over the last 10 years. We have also increased by a factor of 4 the number of radical prostatectomies, which is the removal of the prostate we do with robotics. And for instance, from the statistics of last year, we learned that we had increased the operative load by 10% comparing to the year before.
We are very proud to have obtained in 2014 a quality label from the German Cancer Society. And we have been, since then, over the past 5 years, a certified prostate cancer center. We were the first certified prostate cancer center in Western Switzerland. We achieve highest quality standards in surgical care and diagnostic care and in the treatment overall of our patients. This label does not only cover technical aspects of care, but also patient satisfaction, satisfaction of the people working in the center. The certification covers all aspects of our center.
We are here in the robotic operating room. You can see the robot behind me with its arms that are piloted by the surgeon at the console. Now what happens in this room, of course, is most importantly the operation, but also just as importantly, we have the possibility to record many of the characteristics of the operation. Every part of the operation is filmed, of course, and this is then stored with the data of the patient, and this enables us to review all the cases and make sure quality is there, present at every level, and this of course enables us after that to be certified by the German Cancer Society.
What brings us here to the operating theater is a long process. We have not randomly chosen to operate this man. We have worked up in detail his file. We've had a multidisciplinary meeting regrouping many specialists, examining every different detail of his MRI, his biopsies, his quality of life. And this is the culmination of a long process and a long workup of this particular situation. We have also, on a more human level, discussed with the patient. We have counseled him about the operation, about its effects on his quality of life, and you have answered questions also that his family might have.
I choose this hospital and this country because Switzerland is known for high quality medicine and to have access to all the latest technology. This department is really great for training because they have different urologists who are specialized in all the urologist domains. I mean functional diseases, kidney diseases, oncology, and they have very solid and wide expertise.
Our unit is working very closely with the urology division in developing new drugs and new medication for patients with advanced solid malignancies in the field of urology, such as prostate cancer, bladder cancer or renal cancer, for example.
When we make the diagnosis of cancer of prostate, my first reaction was a little fear because my father was dying of the same illness. So first reaction was difficult. But after that, I have the possibility to consult here in the Hospital Cantonal and the possibility to see several persons, and I will be able to go on and with good reaction from all the staff.
The vision for the future is that, of course, technology will help us improve robotics and minimal invasive surgery. All this should decrease the burden of treatments for the patients. And that, of course, is for us a never-ending goal because we want to be as less invasive as possible for the patients.
Expert-guided tours are invented to have really interaction between the ones who are presenting their work and the people that are experts and discuss the content. And what the good part of it is that you really get a feeling what is good with your research and what you presented and what the angles are and how you could improve your work. So it is very much appreciated by as well the presenters as the people that go to the sessions to discuss what their expertise is, and it has very much added value as compared to other sessions which are more officially done on stage and more in a less dynamic way. People have to send in their abstract in order to be accepted. Then the abstract is judged and discussed and say, okay, this is valuable, this can be presented. We have to turn down about 70% of the abstracts that are sent in, so it's a harsh task. But when you are accepted, that means that you have to build a poster, send it in to EAU office, and it will be presented on a screen. And then you have to explain what the poster is about. Not read it out loud, but just explain, okay, this is what the poster is about, this is the good part of it, also this is the weak part of it, and now let's discuss what the content is. We look at what topics are presented. Some are a bit underrepresented. That means that you can accept a bit more of the abstracts. Some are overrepresented, so you can be more severe in judgment. What you try to do is have a balanced session in order to have as much upper urinary tract as lower urinary tract in order to have the whole picture presented on your session. You really can discuss with the people that do the same work as you what is good and what is bad in the things that you do, and that's why you should join it.
Well, finally today, we've been looking at the science and the guidelines, but one of the effects of prostate cancer that's often overlooked is the impact on mental health. with evidence to show that just the diagnosis of cancer can lead to an increased suicide risk. Well, here at EAU, a series of abstracts are taking a look into this issue, and I'm delighted to have some of the authors with us here to talk about it more. Thank you all for joining us. Zach, we'll just start with you. I'll ask you all, but quickly, could you just summarise very quickly your abstract?
Sure. So we looked at patients that had prostate cancer as well as kidney and bladder cancer, and we looked at this population to see what the impact of a psychiatric utilization was before their diagnosis, and we found that it was increased risk of cancer-specific mortality as well as increased risk of suicide. The suicide aspect is interesting because it's adjusting for psychiatric comorbidities, which has not been done in the past.
Brilliant. And Sophia, maybe you could summarise for us.
Yeah, we did a nationwide registry-based study on men who underwent radical prostatectomy over a 13-year period. And then we focused on the effect of salvage radiation and ADT on the risk of depression. And we found an increased risk of depression in all patients who had undergone radical prostatectomy, and especially the patients receiving ADT had an increased risk for up to 18 years after surgery.
And Carol, what did you find?
Yeah, so we did a mono-institutional study at Oslo University Hospital analyzing the outcomes of 760 patients operated with radical prostatectomy from 2005 to 2010, and we looked then and dichotomized patients to high and low neuroticism. And what we were able to show is that patient-reported outcome measures, as studied by the EPIC 26, were much poorer, significantly poorer in patients with high neuroticism versus those with low neuroticism.
So all these different findings, would you say they're interconnected, Zach?
Yeah, I think so. I mean, I think this is really just starting to come to light. So I think the fact that we're having this discussion is called a debate. I think it's more of just, fleshing out where we need to focus our resources and bringing awareness to this topic.
What would you say the impact of these mental health issues is?
Just to put some numbers on it, we found that after 10 years after surgery, a quarter of the patients receiving ADT had an indication of depression. So that's a lot of men getting affected by this.
Carol, I said earlier, it's something that's often overlooked. Why is the impact on mental health not being looked at more, or is it being looked at enough yet?
I think it's not being looked at enough, definitely not, I think. We start to getting tools and also much greater awareness about mental health issues and outcomes, because it's not affecting only the patient, it affects all the families. So it's getting the baseline of 25% of all cancer, urologic cancer. It's quite a lot.
Would you agree with that, Zach?
Yeah, absolutely. I think, at our center, at the Georgia Cancer Center, we're really starting to develop prospective interventions. And not just interventions, but evaluating how these interventions, do they work? And if they don't work, how can we change it?
We are looking at mental health from different kinds of angles. And our study shows, with only 6 questions that patients can answer in 3 minutes, we can get an idea of patients who have a high versus a low neuroticism. It gives us tools to analyze and start to getting better ideas how to help those patients.
And how do you encourage then people to use these tools better?
Well, I think a couple of years ago they introduced in the guidelines of treatment of prostate cancer that clinicians should be aware of depressive symptoms. I think that's a start. We have to keep assuring that clinicians are aware. Maybe we don't have all the tools gathered yet.
If I can make one more point on that too.
Please.
I think we're looking at their PSA, we're talking about their erectile function, their urinary incontinence. A lot of it's a time crunch. And the other thing too, I think there's a lot of discomfort for the physicians talking to patients about this. So we're trying to get our psycho-oncology colleagues involved very early so that they can handle that. We can handle what we do best, they can handle what they do, but work together.
Well, thank you all for joining us, and enjoy the rest of the Congress.
Great, thank you.
Well, that's all from us today on EAU TV, but what a busy first day of annual Congress it's been. But that is just the start of it. Tomorrow we'll be taking a look behind the scenes as we see how they do it, with Fundació Puigvert preparing to host this year's live surgery. And we'll be focusing on the bladder as we take a look at the plenary session on bladder cancer, and we'll also be having a discussion on stones. Now, there are a whole host of different ways that you can watch the programme. You can watch here at Congress on the big screen behind me, or in your hotel room at a selection of hotels. And of course you can watch online via the EAU 19 news site and our YouTube channel. But until tomorrow, have a fantastic night in Barcelona. Bye-bye.